All right, good afternoon, everybody. Thank you for joining us today. My name is Deborah Holloway, and I'm the Educational and Resource Coordinator at the Brain Injury Association of Virginia. And we're able to bring you this presentation today through a grant from the Administration for Community Living, the U.S. Department of Health and Human Services, and a state contract administered by the Virginia Department for Aging and Rehab Services. I also wanted to let everyone know that we are going to record this presentation for future viewing, and everyone's lines are muted. So if you do have a question throughout the presentation, if you look to your right, there's a questions tab where you can type in a question. And if Dr. Horn's not able to get to your question during the presentation, we will get back with you with an answer as soon as possible. If you would like a copy of the PowerPoint from today, you can also look to your right of your screen and see handouts. It says handouts 2 of 5. One of those handouts is a copy of today's PowerPoint. We're not offering CEUs for this presentation, but we will provide you with a certificate of attendance, and that is a question on the follow-up survey that you will receive after this email, where you can request one and I will email it directly to you. Lastly, the second handout available is live text streaming. It's the directions on how to do that. And this is where you can pull up a separate window that you can open along with the PowerPoint display, and you can view the text live as it's happening. So if you download that second handout, it will give you all the directions and the link to pull that up. Okay. Our presenter for today's presentation, Neurobehavioral Complications of TBI, Behavioral Support Approaches, is Dr. Gordon Horn. Dr. Horn currently serves as the National Deputy Director of Clinical Outcomes Services for Neurorestorative. Before working in National Outcomes, he was the Clinical State Director for Neurorestorative Florida. He has been a licensed clinical neuropsychologist since 1996, providing care across the acute neurological continuum of care. Academically, Dr. Horn completed his PhD at St. Louis University in clinical psychology. He completed his clinical internship year and 2-year postdoctoral fellowship with Duke University School of Medicine, Department of Psychiatry, Division of Medical Psychology, with specialization in neuropsychology, medical psychology, and rehabilitation. So, Dr. Horn, thank you.
You're welcome. Thanks, Deb. So good afternoon, everybody. We're going to talk about behavior support approaches. One of the things that you'll find is that I actually like having questions as we go, because it makes it a little bit more interactive, and hopefully it makes it a little bit more enjoyable rather than just hearing me talk for the entire hour. So please feel free to use that texting function, and I will try to answer things as best as I can. When a question comes along, I will simply restate the question so that everybody can hear it, and then I'll try to give the best answer that I can. So we're going to talk about behavior, and of course one of the biggest complications of behavior following TBI is that, often we look at negative behaviors. But what I'm going to hopefully help you to understand today is that behavior is actually a little bit more complicated than sometimes what we see on the surface. And so if I can make the slides work, here we go. So the first slide that you're going to see, and no, there's nothing wrong with your computer, but you should see a pig smiling. And if you notice the pig smiling, you will notice that clearly these are not his teeth. And if they are, well, then he's got great dental plans. So what I want you to understand is this, is when we first define behavior, behavior is defined as a range of actions that are made by an organism in conjunction with their environment. So it means this. I can't get a pig to smile like this. Clearly, this has been computer doctored, because pigs don't do this. So when you're thinking about behavior, and it doesn't matter with or without TBI, you want to think about what is the context of the behavior, and is the range of behavior within what you would expect the organism to do. And of course, in this particular case, the organism is a human. And so we're going to talk about why it's so important to be able to define characteristics, and then to be able to define things like, is that behavior, does it make sense? So to give you an example, and it's kind of a large example, is this. If I have someone who is paraplegic, then I can't expect that in the normal repertoire of behavior that the person is going to be able to walk. Because if they have a permanent injury, then I can't expect that. So in other words, that behavior isn't going to fit within the context of the person that we're revealing or talking about. And that's really what I want to kind of get across today, because I think sometimes we make gross assumptions and sometimes gross misinterpretations about behavior. The other part about behavior is, you'll see this in orange, is it says it's a response of the system or the organism to various stimuli or inputs. So for example, if any of you are currently listening to the WebEx and you're eating right now, then that means that this seminar is probably going to go pretty well and you're going to feel more positive about it because you're eating. Just like if you're having a cup of Starbucks like I am, then you're going to find that you're going to be more alert during this particular presentation than, say, another one where maybe you're not having a cup of coffee or something that kind of keeps you energized. So we are very responsive to inputs and stimuli, and I want you to think about that in relation to things like TBI. So to give you an example, when somebody is agitated, they could be agitated because they just simply had too much Starbucks, or they could be agitated because of the brain injury, or they could be agitated for a host of other reasons. Neurologic behaviors are those that occur in response to neurologic injury severity, injury location, and what we call psychosocial variables of the individual. And of course, psychosocial variables would be things like the family, things like spouses and kids, things like economic status. It could be things like kinds of job or job performance. So really anything out there that really encompasses the whole social environment of the individual. So that's our prelude. So the objectives for today is hopefully we can identify some challenges and risk factors with neurobehavioral conditions. Hopefully you'll be able to understand really the complexity of behavior, that it's not just a simple cause and effect. And looking at basic understanding of outcomes as it relates to neurobehavioral impairments. One of the things that I actually did not share with Deb, but I can certainly send it her way, is we actually have an article that we published about a year ago specifically on neurobehavioral syndromes. And this is looking at actual treatment for neurobehavioral disorders. And what it demonstrates is the efficacy of that treatment. And so certainly if anybody is interested in that article, you're more than welcome to have it. It's actually considered open source, so we are free to share it with you. And then finally, we're going to look at different behavioral approaches to behavior management. Now, of course, this isn't a course on behavior analysis, but I am going to give you some good resources for day-to-day activity. So for anybody who's on the line who happens to be a family member or an individual who's been injured, then hopefully some of this will apply to you. And for any professional who's on the line, then when you're working with an individual that may have a behavior problem, then hopefully this will give you some resources to be able to work with. So I start out with this picture, and if you look to the right of the picture where you see the darkened hand, and then you look to the left and you actually see that it's a rabbit with the with light coming in from behind the rabbit, you'll notice that it's not always what it seems. So if I look at the picture to the left, then I see that it's a rabbit, and if I look to the picture to the right, then it looks like somebody's hand, or specifically somebody's left hand. And this is exactly what happens with behavior. Sometimes what you see on the surface isn't what you get. So let me tell you about this individual. This is an actual case, and this is a person who was a pedestrian and in a major metropolitan city within the United States. And the person was crossing a crosswalk, and the person had the right-of-way and was then hit and actually run over by a delivery truck. And what happened is that as the person was hit, unfortunately, the person just at the very end was able to actually see the truck coming. But because of the impact of the truck, it then caused severe orthopedic injuries as well as a severe head trauma. Needless to say, the person had a positive loss of consciousness. And by all rights, in terms of going through the process of recovery, the person was considered to have a severe, moderate to severe traumatic brain injury. Now, this person was injured several years ago and actually has been continuing to progress and improve. However, here's what you'll see if you were to meet her, let's say in a Starbucks or let's say on the street. You would see a very nice looking 27-year-old or now about 31-year-old who by all rights looks exactly like all of us. So, walking, talking, there's absolutely no indication when she's walking or going down the street that she's had massive orthopedic injury. The individual does all the normal things that we all do. So if you met her, and you had a conversation with her, you would have absolutely no idea that approximately 1/4 of the frontal lobe is actually missing. So what happened is that the trauma was so severe that it caused a fair amount of swelling to occur, and then it caused a severe amount of atrophy to occur, where she actually lost brain tissue. Now, why that's important is this. If something were to cause her to get upset, then she gets upset going from 0 to 100. Whereas you or I might get upset, and we may only escalate to, let's say, 0 to 20. So for example, if she's got to get to the airport and she begins to run late, what she then does is she'll run traffic lights and she'll go 90 miles an hour down a side street in order to get to the airport. And at one point in time, she actually did this and was followed by the police, and they pulled her over. And thankfully, they didn't arrest her, but they were very close to arresting her because she was violating multiple traffic rules and regulations. Because in her head, the only thing that she had to do was she had to make her flight, because the flight was in relation to doing what's called an independent medical exam. And so for her, the behavior became very aggressive, and it became very dangerous, not only to her but to other people, because she could only focus on that one thing, which was she had to make it to the airport. And of course, the police were looking at it going, yeah, but this is a real safety issue. So needless to say, she got extraordinarily upset. And by the time she actually did make it to the airport, she was, again, just so distraught, and her behavior was just completely aggressive at this point, that it was amazing that she actually got on the flight, and it was also amazing that she didn't get asked to get off the flight. But this is a person that if you met her under low stress conditions, you would say, well, gosh, she is no different than you or I, meaning that she, does everything normally, and she does up until the behavior gets severely triggered. So when we talk about behavior, I want you to think about the things that you normally see in behavior, but I also want you to think outside the box. I want you to think about, well, what are the other potential reasons as to why a person may be behaving the way that they are? Behavior often seems like it's this tug of war, where it's kind of good, bad, good, bad. And sometimes the tug of war seems to be persistent. And usually when we see this kind of persistence in behavior, what we want to do is start looking at what's called the root cause. A root cause analysis, what it essentially means is this. It means that you're trying to find what is the underlying mechanism that's actually leading to all of this behavior. So in the 27-year-old, what the underlying mechanism is that approximately 25% of her frontal lobe is no longer functioning. And she's actually had atrophy within that frontal lobe, which means that is not going to come back. And so when you look at her being aggressive, one of the things that I've certainly talked with her family about is, in the event that she were to get arrested, then their first phone call needs to be to me, because this is a patient that I actually did an independent medical exam on, and this is a patient that I have very clear documentation that says she has severe brain pathology. So let's not treat her as being an aggressive criminal, and let's not treat her as being a rule violator. Let's work with it in relation to how the brain injury got triggered and how the agitated aggressive behavior actually makes sense in relation to her injury. And so those are the kinds of things where, again, a root cause analysis is extraordinarily important, because then you won't be treating the wrong thing, or you won't be making gestures or efforts to correct something that really may be not the most appropriate thing to try to correct. Now, here's a couple of things to think about. I want you to think about what you would consider to be as being positive behaviors and negative behaviors. And I want you to think about why you characterize them or classify them as being positive or negative. Because everybody is going to have a slightly different twist on what they consider to be positive or negative. I'm going to give you an example. So I have worked in many areas of rehabilitation, from ICU all the way through the entire continuum of care. And one of my specialties is always working with neurobehavioral syndromes. And one of the reasons for that specialty is simply because if you understand behavior, then you understand how to make treatment, and in which case then you become a very valuable resource. So in my world, because I deal a lot with neurobehavioral syndromes, then having somebody become agitated or even having furniture or something thrown towards you or towards something or someone is kind of normal in my world. So to give you an example, one of the facilities that I ran a number of years ago, I was in my office. It was about 6 o'clock one evening, and all of a sudden I heard this crash. And keep in mind that my office was right in the middle of the campus, and it was in an administrative part of the campus. But there was an apartment, I had 7 apartments that were behind where my office was. And so in that residential area, all of a sudden I heard this large crash and bang. And I thought, well, one of my managers is going to be knocking on my door in probably about 2 minutes. And so sure enough, one of our maintenance guys comes up to my office and he says, Dr. Horn, he says, just wanted to let you know. He says, apartment number 4 has a busted window. And I said, is that the noise that I heard? And he said, yep. And I said, so what happened? And he said, well, he said, the chair that was in his living room is now in the parking lot. And I said, okay. So to me, that is something that is kind of within the context of what we were there to be able to work with and treat. And by the way, that person actually never threw another piece of furniture through the window again, because again, we had them on a behavior plan, and the behavior plan worked over time. But if you ask me what is abnormal behavior, I might say to you, well, throwing a chair through a window, although that seems odd and unusual, in my world, that's not really an unusual behavior overall. However, if you're used to working at an outpatient center where you have patients that come in from 8 to 5 and somebody throws a chair through a window or through a glass door or what have you, well, that becomes highly unusual, and it also becomes highly negative because of the context that you're in. So that's why I want you to think about what would you consider to be positive and what would you consider to be negative. Now, here's why. If you look on the screen in front of you, you'll see where it says positive behaviors. And often positive behaviors have really no risk. And so what unfortunately happens is this. We often forget to reinforce good behavior or positive behavior because we get so focused on negative behavior. Now, the 7 behaviors that you see in front of you that we consider to be positive, this is some of the work that I've done with the University of South Florida a number of years ago. And in working with the behavioral analysis program there, we actually came up with these 7 things that are the most frequent positive behaviors that we try to enlist or try to enhance when we're working with somebody in a post-acute neurorehabilitation program. So for example, social courtesy or consideration to others, social skills use, problem solving, appropriate requesting, self-calming, safety awareness, acceptance of feedback. One of the things you'll notice that's a common element or a root of all of these behaviors is we're trying to impact positive social behavior so a person has a better ability to be around other people, whether they be family, friends, or just anybody randomly in the community. Because in neurobehavioral syndromes, one of the most complicating pieces is having a person's behavior being appropriately managed so that they can have access to the community no different than anyone has access to the community. But if you keep telling people to flip off, or you keep, going after people, or you keep being aggressive, and you periodically get arrested, or the police are constantly called on your behavior, then what happens is that you can't interact with the world, and the world doesn't want to interact with you. And so what we try to do is we do what are called replacement behaviors, and that's what you see in front of you. This is where we work on these consideration to others and social skills, problem solving, and so on. Now, also to think about is why do we consider something negative? Well, often it's because there's a risk, and the risk is what we actually tend to focus on, and we're trying to then reduce that risk. So to give you an example, the gentleman who threw the chair through the window in his apartment, the risk is that as that chair is flying through the window, I don't want that chair to hit somebody else that we're serving or to hit one of my staff. So the risk is that it's dangerous to other people. But the risk wasn't to the person who actually threw the chair through the window. because he was throwing the chair away from him, so he wasn't going to get hurt. But somebody else could get hurt, so therefore we had to assess the risk. But what I didn't do is I didn't respond to that risk. So in other words, the person was already on a behavior program, so we just maintained and continued to adapt his behavior program. We didn't change anything just because the chair went through the window. But of course what we did do is we made sure that everybody was safe from that point forward. So if you look at the 7 things that are underneath the negative behaviors, you notice that they all have risks. So verbal outburst is a risk. It's a risk socially. If you're out and about, and if it's a guy who becomes verbally outbursts or verbally aggressive, what tends to happen? Well, you're going to get some other guy who probably is not injured, who's going to then start getting into that person's face. And as a result of that, now you're going to create a problem. Because now we're going to create a problem where socially we may have everything begin to break down, and now we have to worry about physical aggression and physical violence. So you can see that each one of these things has a risk to it. And what we're always trying to juggle is, can we deal with the risk so that we can deal appropriately with the behavior, or does the risk outweigh the behavior, and in which case then we have to create safety, and then we deal with the behavior. Elopements. The risk with elopements is actually more on the person who's eloping. This is where a person is leaving a facility because they're unauthorized to leave. And what we worry about in the elopement is actually the safety of the individual, because they may get themselves into a bad situation with somebody else. They may, all of a sudden leave the area and then get lost and not know where they are. They may not have money, so all of a sudden they get in a cab. Then the cab delivers them somewhere, and now they can't pay the tab. Well, that's a misdemeanor, and you can go to jail for that, and so on. Impulsivity, the risk is I'm going to do something that creates harm to me or somebody else because I can't think through what I'm doing at the time, and then I can't analyze and judge that risk. And of course, there's self-harm behavior. So if a person is highly distressed, or if they do things like cut on themselves and so on, then of course the risk is that they're going to harm themselves in such a way that might require hospitalization. So now I want you to think. I'm going to give you a scenario. So now you've heard the positives and you heard the negatives. I had a gentleman who was in one of my facilities, and in working with this gentleman, he came to us and he was drinking alcohol and taking what are called Xanax bars every day of his existence. So in other words, he was constantly high and drunk. And one of the reasons why I agreed to have him come to the facility to work with him, he obviously had a brain injury, but it wasn't the brain injury that created the substance problem. He had that before the brain injury. But the brain injury then made his control of that even more difficult. So he comes to us, and within 30 days of working with us, his drinking and drug use went down to 0. And his drinking behavior went down, we reduced it by 98% in 30 days. We were aggressively working with him, and here's the thing. What we did not do, which is what most people would have done, is we did not restrict him from being in the community when he was done doing his treatment day. Now, he lived on my campus, but he had access to go into the community. And most people would be like, well, why would you do that? Because he's going to get access to drugs and alcohol. And of course, the reason is because we want to be in a real world context, and we want to help a person to move forward. We don't want to restrict and then release the person, and then all they do is go right back to the old behavior. We want to create and substitute negative behaviors for those positive replacement behaviors. So he's doing extraordinarily well, really responds to the program, and he's just a great guy. So at day 45, his mom comes in, and remember, this is an adult, but his mom comes in, and she charges into my office with a full head of steam, and she says, "You let my son drink." And I said, "Well, would you like to come in?" And she says, "Yeah." And I said, "Okay, well, why don't you sit down?" And I said, "Why don't you explain to me what you mean by I allowed your son to drink?" And I said, "And remember, let's keep this context appropriate. He's of age, and he's his own guardian." So I said, so we have to be looking at that right there. So she says, "Well, he had a couple of beers the other night." And I said, "Yes, he did." And I said, and he came back to the facility, and he told us about it, And he told us that how, what he basically was feeling and why he did that. And he told us about it so that way we could help him to not do that again. But yes, he did. He had a couple of beers. And I said, in the 45 days that he's been with us so far, that was the only time that he's actually had alcohol, and he self-disclosed. So I said, he did the appropriate thing. But I said, you're asking me to now punish him for a behavior that has only occurred approximately 1 to 2% of the time that he's been with us. And I said, why are we focusing on that? That makes no sense, because 98% of the time, his behavior has been very appropriate. And his behavior not only has been appropriate, but he's been working with other participants who are in the facility who are trying to get better. And he's a good guy. He's working. He's going to all of his therapies. He's participating in counseling services. We're dealing with the substance issue from a long time ago. I said 98% of this program's working and only 2% not. So why are we focusing on the negative behavior? Because the risk wasn't that high. The behavior was a problem, but the risk wasn't that high. And so what I tried to explain to the mom is, we don't need to go there. Now, as you see the guy with the electric socket here, one of the things that we do is when we're looking at positive and negative behaviors, we need to measure this so that we can determine what the proper intervention is. And if you heard what I said about the example, 98% of his behaviors were appropriate. Only 1 to 2% was inappropriate or was somewhat harmful or potentially harmful. So that's a low frequency, and it also means it's a low intensity. So that's what you want to be careful of, because sometimes we all of a sudden focus on a behavior, and really it's a very infrequent behavior, which means the more we focus on it, the more likely that behavior is going to then continue to worsen or increase in intensity or frequency. So behavior plans help us to determine if other things, such as the environment, is contributing to the behavior being triggered. So I just like this example because it's kind of a funny example, and the question is, would you stick your finger in the socket, or would you pull that wire out as it's actually burning? And of course, he's got a great hairdo there. All right, now I'm going to tell you about a condition because I want you to then see again how sometimes the unobvious is more important than the obvious. If you've never heard of this condition before, it's called progressive supranuclear palsy. It is unfortunately a degenerative dementia. And so you first have motor symptoms, and you first have some very unusual symptoms that can be very hard to detect. But unfortunately, over the course of time, meaning usually within about 6 months to about 3 years of diagnosis, the person has a very steady and progressive decline. Well, one of the things that actually happens in this particular condition, it's also known as the Steele-Richardson-Ozlowski syndrome. They were the folks that actually discovered it. But one of the things that's really a hallmark feature of supranuclear palsy is this. When the person talks to you, they have a hard time looking directly at you and at your eye. And what will happen is they'll look at you for a brief second, and then they will actually turn away. And people misperceive the combination of the eye movement turning away and what we call facial masking. And what it means is that the person's facial expressions become very blank, and they almost look negative. You'll also sometimes see the eyebrows actually kind of squeeze a bit like a person's frowning. Well, what's interesting in this particular condition is it is the combination of the facial masking, that little bit of a frowning effect that you may see, and the looking away, that what happens is these patients at first get pegged as being, they're not interested, or they seem mad that you're talking to them, and they seem disinterested. And what sometimes happens in healthcare is that providers, if they're not familiar with this condition, because it's a degenerative neurologic condition, then they misperceive the person's behavior as being negative and disinterested. And what they then do is they respond to that negative, disinterested, perceived behavior. And what they then do is they become disinterested in the patient. And they write the patient off as being, this is a person who's a pain, and I'm not going to treat them because they're not understanding what I'm saying. When in fact, they understand everything just fine, but they don't realize that the facial expressions and the lack of eye contact is actually causing the problem to occur socially and behaviorally, even though behaviorally they're as engaged as they can be, but they have these symptoms. So it's a really interesting thing. Another example I used to see in the hospital all the time is I would hear people say, I need you to see Mrs. So-and-so because she's so depressed. And I'd say, well, why exactly are you telling me that the person's depressed? Well, oh my gosh, if you just look at them, they just seem really down. And I go, what tells you that they're really down? Well, they just don't have much in the way of expression, and nothing seems to be interesting to them. And I go, well, hold on. The kind of stroke that they have is a right hemisphere non-dominant stroke, and that stroke causes facial masking. It also causes what looks to be a disinterest, and it's actually not. What it is that they're not initiating social behavior. And so when you look at them, they look very flat, and they don't recognize, because they have a condition known as agnosia, which means they can't recognize that their facial expressions and their emotional responses don't fit. And they may interpret your facial expressions, but they can't reciprocate by giving you a facial expression that then matches. And I said, actually, I already know Mrs. So-and-so, and Mrs. So-and-so is not depressed at all. In fact, Mrs. So-and-so is actually looking forward to the rehab process to be able to get home and to be able to do all the things that she wants to do again. And she's completely unaware of the fact of what she appears to be. So it's an example where somebody all of a sudden wants to throw out a clinical diagnosis, and what that would then stimulate is the use of things like an antidepressant. And an antidepressant doesn't do anything for this particular condition. And in fact, you might complicate it because you're adding something that maybe doesn't actually even need to be part of the treatment process. So hopefully you're beginning to now see how sometimes our behavior and the way that we look and the way that we present are often extraordinarily misleading. And it's not because we intend it to be, it's simply because it is, and of course in neurology, it is because it's part of the neuropathological process. So now let's talk a little bit about the science. So far I haven't seen any questions, so that either means that your lunch is really good, or it means that you may have fallen asleep, or it means that so far so good and you're liking the presentation. Hopefully it's number 3. So let's talk about the challenges of etiology. And etiology, putting it very simply, just simply means what's the underlying cause. So in neurologic injuries, the challenges that are faced by patients, support systems, and professionals are highly varied. However, the challenges can be categorized for ease of understanding. So here are the categories. And we're going to go from basically a bottom-up approach. And I don't mean that in the sense that it's less important. It's not. Each of these levels has their own level of individual importance. On the biological or biochemistry side, we know that the cells are dysfunctioning. We know, we know that we have to have repair, and we know that plasticity will help the brain to improve. And one of the ways we help the brain to improve at the biological level is sometimes we use medications, and sometimes we just simply have to give enough time for the cells to rework themselves and to basically get restarted. But at the biochemistry level, things that affect behavior include serotonin, melatonin, norepinephrine, and dopamine. Those are the primary ones that actually produce behavioral disturbances. Dopamine is our system that allows us to have memory, learning, and very complex processing, but it also is involved highly in motor functions, motor capacities, and it also helps us to organize our thinking. So things like higher level problem solving and planning. When it dysfunctions, one of the key ingredients is you'll get hallucinations and you'll get delusions. Depending upon the level of dysfunction, depends upon the level of symptoms. There's a degenerative case that I had recently seen where this degenerative case is the person has what I believe to be a condition known as Lewy body syndrome. And what's happening in her behavior is her behavior gets very disruptive very fast because she first starts out with what are called tactile hallucinations. And the tactile hallucinations means that she has a sense of burning metal that is poking out from her bones. And so everything hurts. And when the intensity of that pain increases, then what happens is she begins to hyperventilate. When she hyperventilates, then it basically what we call dissociates. It means she kind of separates away and she goes into this whole other thing, and nobody can kind of recapture her behavior to bring her back down. medicines have been very ineffective, and the reason why we think it's Lewy body is because it's a progressive dementia, and medications have been very ineffective to help us to then reduce the incidence of these hallucinations. We know that this is coming from dopamine. We know that. But what we can't figure out is what level of dopamine, and we can't figure out what to do to stabilize that dopamine because it's an ongoing process. On the neuropathology side, this is where we talk about tissue and physiology. If you remember the case at the beginning of the talk, what I talked about is the roughly 30-year-old female who got run over by a truck that, you know, she walks and talks and she looks absolutely fantastic and she looks like everybody today. However, when you look inside of her brain and you see that about 25% of the frontal lobe is missing or that it's atrophied, that's the tissue, that's the physiology, that's the neuropathology. It says that when we look on scan, I can point to the area that no longer exists. And I can say, because that doesn't exist, then this person can't do X behavior. On the neurobehavioral side, this is where a person then puts together their whole process of recovery. Now, one of the key ingredients in neurobehavioral disorders is this. You have to be injured for a minimum of 8 months before we consider you to be a true neurobehavioral disorder versus having neurobehavioral problems as a result of the acute trauma. And the reason why we say that is because in trauma, we know that post-traumatic amnesia and we know that post-traumatic behavior syndromes occur as part of the natural process of recovery. But after 8 months, all that actually settles down on the neurology side, and now what you're beginning to see is where behavior now is going to become more chronically impaired. The earlier we can identify that, then the better we can intervene, and the better we can divert it to where it's not incapacitated. On a neurocognitive side, people will get behavioral disruptions when they have things like language impairment, such as aphasia or apraxia of speech, things like being unable to comprehend what people say. If you've never tried this before, try, listening to a foreign language that you don't know. And imagine yourself listening to somebody speaking with all the right intent and telling you something that's reasonable, and you're just looking at them going, I hear you speaking, I see you talking, but I don't have a clue what you're saying. That's what it's like to have a receptive aphasia where you can't comprehend what people say. Or the expressive aphasia, which is highly frustrating. And when aphasics get frustrated, they will tend to tighten up their fists, they will tend to bang on tables, or they will tend to throw things out of frustration to explain to you that this level of communication is so tormenting that I need to stop. And so the goal is to teach people how to and have that resilience so they don't get to that level of agitation. But neurocognitive impairments, such as the language impairments, but also in terms of attention and processing and memory. How useful is it if you can't remember things? And how difficult is it to get around in the world when you can't remember things? Like, for example, how did I remember to show up today for this presentation? How did you remember to show up for this presentation, and so on? And then, of course, psychosocial variables, which we've kind of talked about. So what you see down at the bottom are the examples of residual behaviors, and you can see how different things are really causing or can cause things like agitation or neurobehavioral syndromes. Just a couple of quick things, and I'll kind of move on from here. We know that medical health, especially as it relates to brain injuries, has this what we call an interaction effect. We know that diabetes can create agitation, irritability, and confusion. Well, so can brain injury. And when you put those two things together, it's like a smoking gun, where it can really create quite havoc. We've actually run 2 studies where we looked at depression and anxiety. One of them is actually now coming out. It's actually, I think it's now in print. It's in the Journal of Neurorehabilitation, and this is on depression and the effects of depression. And then we also looked at the effects of anxiety that's currently in process. And both of those research studies actually demonstrated that anxiety and depression alter the behavior, which then alters the outcome. So our goal in rehabilitation is to treat what we see, but the key is the diagnostics. You have to basically evaluate properly. You can't go by sometimes what you see. You have to go by a full assessment of looking at things like anxiety, depression, irritability, agitation, and so on. You have to use multiple measures, and you have to use multiple collaborative sources. as an example. And then there are some other things as well, things like occupational history, substance abuse history, financial considerations, and so on. If you think about your own finances for a second, and if you've ever been in a position, so for example, I'll take us all back to 2007, 8, and 9, when we had the major financial crisis in the United States and in the world. If you think about the amount of stress that you were under during that time, feeling like, my gosh, my house isn't worth what I thought it was, feeling like people are losing their jobs and losing homes and cars and everything else. Now think about that in relation to now having an injury that's catastrophic. How would you handle that kind of stress? Because the question is, how did you handle it without an injury? And so the injury just simply magnifies those processes. What we know is that behavior, whether it's from neurologic injury or from other source, is highly complex, and hopefully you're beginning to see that. Most of the behaviors also involve cognitive processing, conditions of the behavior, persons that's in the individual's life, social and financial aspects, legal considerations, and so on. I'm going to keep going because of time. We also look here in terms of what I call synergy, and this is where we put together behavior as a combination of the culture, the values, our attitudes. That's without an injury. And then with an injury, put injury in the middle of that, and then what it can do is it can accentuate all that, or it can impair all of that. This is an example of when we look at the step-down process of rehabilitation and we look at neurologic injuries. You'll notice that the number of X's increases as you go across the page from left to right. And what happens is each of these X's represents another aspect that can then completely influence a person's behavior. So when you're in the neuro ICU, we only care about your medical history. We care if you're married or not, or you have a support system. And then we're worried about the financial piece of it, so we know what it is that can be done and when it can be done. But you'll notice that by the time you get to outpatient, home, and community, then it's more than that. Now we're looking at the influences of things like education, substance abuse. We're looking at anxiety and depression, and so on, because the further you get away from the acute trauma or injury, then the more complex it becomes. But here's the crazy thing. About roughly 80 to 90% of our funding for brain injury, whether it be traumatic, stroke, or another kind of acquired injury, we tend to put 80 to 90% of our funding into hospitalization and into the trickle-down effect into outpatient care. Very little of the funding goes into outpatient therapies, post-acute rehab, and home and community rehab, which is kind of crazy because 90% of recovery is during the post-acute phase, whereas 10 to 15% of the recovery is only in the acute phase. But the financial piece of it is exactly the opposite. So again, we got to kind of figure this out because we can really divert many complications and problems the earlier that we start dealing with things. If you've never heard of the Mayo Portland Adaptability Inventory, then now you have. This is something that is used in the post-acute arena, and it's used because it's a very good comprehensive measure. And these are the actual components of the Mayo Portland that you look at in relation to creating what's called the Neurobehavioral Syndrome. So again, injury has to be 8 months or greater. You are high or moderate to severe on irritability, agitation, aggression, impaired awareness, impaired social interaction, and impaired problem solving. We actually had a recent article at the end of 2016 that was published on the Neurobehavioral Syndrome, and that we look specifically at what are all the different aspects. And what you see in front of you is the reference, so you can certainly look it up. It is open access, so feel free to download it. It is free. We know that neuropathology, the frontal and temporal systems are the ones that are really most involved. We know that from the frontal lobe, that is your regulatory mechanism. And so when the frontal lobe works, it's fantastic because then we can do what we need to do in relation to the demand on us. In the temporal lobes, this is what helps us to then be okay from a psychological, emotional, and behavioral component, meaning that how we feel is first spurred in the temporal lobes, and then from there it is then refined in the frontal lobes, and that's how we're able to get along day to day. Well, unfortunately, in brain injury, the frontal lobes and the temporal lobes take the biggest hit. In most traumatic brain injuries, of course, and in some stroke and in some acquired injuries like aneurysms, brain tumors, and so on. Remember that different kinds of pathology, meaning traumatic brain injury, stroke, aneurysm, brain tumor, anoxia, encephalopathy, encephalitis, different medical neurologic conditions will produce very different kinds of responses, which then in essence produces very different kinds of behavior. For those who work in acute care, then we use the Ranchos Los Amigos scale and we use the Glasgow-Coma scale. When we look at severe injuries and we look at severe behavior during Rancho level recovery of 3, 4, 5, then typically what we do is we control the environment and we control through medication. Medication can be extraordinarily helpful in the early stages to really help to kind of temper behavior so that a person can then fully engage in their recovery process. At a moderate injury, where we're looking at Ranchos 6 and 7, this is where we now start to get more complicated, where we still want to control the environment, and we're probably going to use medication. But now we can begin to ask to get the person to start using their cognitive skills, and we can start engaging the family in managing some of the complexities at home, as an example. In more mild injuries, where we're really talking about Ranchos 7 and 8, this is where a person's cognitive processing is really then emphasized. We teach you cognitive rehabilitation skills. So things like, how do you pay attention better? How do you know when you're fatigued and when you can no longer process information? You've been listening to me for about 50 minutes so far, so right now you're starting to get to your peak of performance when it comes to cognitive processing, because most people can't really do it longer than about 40 to 45 minutes. So that's why I try to be a little bit entertaining. On the post-acute side, now we're looking at the social environment. We're looking at not only the environment in terms of what you do, but we're looking at who's involved in your environment. We're looking at all these other contributing sources like, can you return to work, part-time, full-time? Are you returning to school, part-time, full-time? Are you also using cognitive resources, and are you using what we call pacing techniques? This is where you're going to then create a schedule and a flow where you work and then you rest, and then you work and then you rest. And you go back and forth to get the brain to become much more resilient. The hardest part about the post-acute phase is that old behaviors tend to resurface. So the gentleman I was telling you about who was drinking and using Xanax every day, this is a person who was post-acute by about 5 years. And so clearly all of his old behaviors that were existing before the injury certainly then reemerged or resurfaced. And that's why we created this program to deal with both the substance aspect as well as the brain injury and post-acute rehabilitation process. We already talked a little bit about anxiety and depression, but just so you know, depression has a 34% incidence rate at any time in recovery. So not just in the first 6 months, not just in the first year, not just in the first 2 years. Any time in the process of return and recovery. Anxiety has a higher range of roughly 20 to 70%. In our study, we actually found that it had a rate of about 42%, which makes sense because it's right smack in the middle. But the point being is this, at least 1/3 of those who are in a recovery process are going to experience anxiety and or depression, or both, potentially. We know that social and family involvement is also a complexity. We know that those who've been married over a longer period of time tend to stay together better. We also know that those who've been either newly married or newly in a relationship where one person becomes catastrophically injured, that unfortunately that social environment tends to break apart. We know that the person's family of origin tends to be the most important, and it also can be the most disruptive depending upon the family dynamics and circumstances. There's also family dynamics that can be very cultural, that can not only help the process of recovery from a support standpoint, but sometimes can interfere with the recovery process, because in some cultures it's more important to, quote, take care of people than it is to allow the person to learn through repeated behavior management, as an example. Educational effects, what it means is this, is that typically you have a little bit more resilience with higher education, and from an occupational standpoint, depending upon your occupation, depends on how frustrated you get as you get to return to working. So for example, when I've evaluated pilots, one of the things you have to be extraordinarily careful of with a pilot is they have to be in very good control. They have to have good executive functions, good memory, good processing. And so if somebody doesn't demonstrate that level of performance, then they're not going to be able to return, because the FAA won't clear them to return. And I've worked with many pilots who were not able to return, and they get highly frustrated because now they can't do the thing that they love doing, as an example. One of the things I just wanted to show you was the line that's in red is what neurobehavioral impairment does. The line that's in blue is what you see in active neurorehab, where a person has no behavioral impairments. And then the green line is more of a control sample. These are supported living folks who aren't getting active treatment. And what you'll see essentially is that neurobehavioral impairment actually reduces the recovery process. So the line in blue almost is shooting straight up, and that means that the recovery time is much faster. We actually found in our research that neurobehavioral syndromes will significantly reduce recovery by 2 to 3 times. So if it takes you 6 months to show good recovery in neurorehab, then it will take you on average 18 to 24 months to be able to show that same level of recovery, because at least half of that time is going to be spent on reducing behavior impairments. These are some of the studies that you can, again, go back to, and I just kind of summarized them for you. But we've been actually doing research since 2013, and we've been publishing on all of these issues. And now this is to make sure that you're still attentive for the 45 people who are still on the line. And so hopefully you're laughing when you're looking at both of these things. The question is, which behavior is normal? Is it the donkey that you see up top, or is it the zebra that you see to the left? And hopefully what you said is, well, yeah, I think it's the donkey that's to the top. And the answer is, of course it is. Zebras don't look like they're dancing. They don't look like they're night clubbing because they can't. So the idea here again is make sure that when you're looking at behavior, behavior has to be specific to that particular individual or that particular organism. And you have to look at, is it part of the natural sequence of things? So for example, if we're working with somebody who only completed to the 8th grade, then we have to be careful to teach the person by giving them handouts. It doesn't mean that they can't read, but it means that that's not going to be their preferred way of learning. And if it's not the preferred way of learning, then they either won't or they'll resist the treatment because you're asking them to do something that doesn't make sense in their repertoire of behavior. So instead, somebody like that, what we may do is use more visual training, more hands-on training. And if we give you handouts, it's going to be pictures rather than words. And that in and of itself can reduce behavioral problems and behavioral impairment. One of the most important things about behavior, but treatment in general in rehabilitation, keep it person-centered. It has to be about what the person's goals are. It's not about what your goals are as the professional. It's about what the person wants to accomplish. Number 2 is be supportive. Number 3 is simplicity. One of the things that I see commonly when I get asked to review cases is if there's been a behavior plan involved and the person's still getting frustrated, agitated, irritable, whatever, what I often see is that agitation and irritability is the result of a behavior plan that's too complex. To give you the example, don't have 12 goals. If you have 12 goals, who's working on what? And what happens is you work on none. Instead, in behavior, you have 1 or 2 goals max, and you work on just those things until you begin to see change. Consistency, flexibility, and most of all, be positive. Behavior is often just an outreach of what's happening on the neurology side. I was trained in behavioral neurology, and as a result of that, we use behavior as a diagnostic tool. We don't use behavior to go, oh my God, I don't want to be near this person. Because again, it's telling you about the expression of the brain. And lastly, when we look at reducing behaviors, just remember 3 letters, A, B, C. Antecedents, behaviors, and consequences. Antecedents are what's happened before the behavior was demonstrated and what led up to the behavior being started. The behavior is defining it. What is the behavior? What's the frequency? What's the intensity? And then third is the consequence. In other words, after the behavior existed or was demonstrated, what happened? What did people do? Did they reinforce it by focusing on the wrong thing? Like, do we focus on the 2% of the time the person was drinking, or did we focus on the 98% of the time that the person was not drinking? We look at things like punishment and extinction. Just so you all know, punishment should never, ever, ever be used because it actually has no effect in the long term. Punishment will change things in the short run, but you will actually drive behavior into a more problematic situation if you use punishment. In behavior terms, we like to use extinction, which is where we just simply don't reinforce bad behavior and you reinforce good behavior. Of course, it's more complicated than that, but that's the general gist. Just a couple of things for home need. First of all, applying skills at home is always preferred because then you're out and about. You want to see how behavior skills get carried over. Education of family and professionals, intermittent professional services to help to intervene, and activity. Home activity equals better behavior. Reduce stimulation, keep the environment calm. Take breaks, leisure activities, development, apply things into the community so that you get good at being able to have good social behavior awareness. Also, make sure that you keep in mind fatigue. Fatigue is one of the highest complications in behavior, meaning that it can cause disruptive behaviors. For those of you who have kids, especially kids who are 5 years and younger, you will notice their behavior substantially changes when they're tired versus when they just get up from a nap. When they get up from a nap, they're usually warm and cuddly, and when they need a nap, they're usually just a terror, and they usually get into tantrums. Cognitive overload is also another major complication in brain injury. The more overloaded one becomes, the more disruptive the behaviors become. And in summary, we know that behavioral disorders do exist and neurobehavioral syndromes do in fact exist. So Deb, I'm going to turn it back over to you, but that's everything, and I think I finished right on time.
Great, yes, thank you so much. It looked like you had one question.
Okay.
In the question box, but otherwise.
I don't see it. Do you want to say it out loud for me?
It was back about would a diagnosis of PSP apply to a person who's had a stroke? Was a question.
Yeah, the answer is no, because progressive supranuclear palsy is a diagnosis in and of itself. It is not considered a symptom of another diagnosis.
Okay, great.
Yeah, great question, though.
Okay, thank you so much for joining us. I appreciate it. Thank you, Dr. Horn.
All right. Well, you all have a great day.
Thank you.